So this is the first step, the Capsulorhexis, which I think is one of, obviously, as you mentioned, one of the best parts of doing femtosecond laser. And so we typically use a cystotome to start the capsule, and then it can be either completed with a cystotome or completed with the Utrata forceps. Great. And so what are the benefits of having a really great Capsulorhexis? I remember one of my surgeon mentors used to always say that's kind of like your stamp, so that in the future, anytime any patient looks at this, or any doctor looks at this patient's eye, they're going to see your capsulorhexis. That's what they first look at, right? But besides all of that and the art behind it, it actually does, it does affect tilt. And that's important for the effective lens position. All of our calculations that we perform prior to surgery are all based on guessing the best effective lens position. So if the capsulorhexis, certainly the symmetry, the placement of it is so important, because if it's not exactly correct, it can result in lens tilt. And especially when you're using a premium IOL and these defocus curves really need to be so precise, that can affect the visual outcomes as well. And even with monofocals, the same thing. It's really important. So here's a comparison of manual versus femtosecond laser, and this is looking at the deviation. So obviously, when you have a femtosecond laser, there's not really even a close comparison how circular it is and how uniform it is. So you can see the deviation from intended diameter. For manual, it's going to be 329 versus lasers 27. So as you're making the Capsulorhexis for various different reasons, it can slip a little bit out if there's zonule issues. Let's say it's pseudo exfoliation, different reasons. You can't get a perfect circle every single time. So if you compare the manual on the left to the laser on the right, and these are all stained by trypan blue, you can see what a difference there is. So as I was mentioning about the kind of that's your stamp. So here's a perfect example. So years later, when we're looking at the patient's eye, you can compare how it looks like if they've had femtosecond laser versus a manual capsulotomy. The importance of IOL centration. So as I discussed earlier, it's going to affect the IOL effective lens position, and tilt does matter. Also, decentration does matter. The nice thing is when you can, I know for the LENSAR, you can actually focus, you can actually choose where your capsulotomy is, pupil center versus the visual axis. And so you can actually make sure that Capsulorhexis is centered exactly where you want it to be. And that's going to be really great, especially for our diffractive optics IOLs. And so as the last point says, multifocal EDOF IOLs induce higher order aberrations by design. And so since we already have HOAs there, we don't want to introduce more by having any kind of detrimental effect on the effective lens position. This is a study showing the comparative visual outcomes of an EDOF intraocular lens. They use the Symphony lens by Johnson & Johnson with FLACS versus conventional FAAO. And what we saw with the FLACS is that there is significantly lower IOL decentration and tilt. And that's going to be important, especially in the setting when you have an EDOF lens. And so therefore, because of the IOL decentration not being too bad, there is also significantly lower higher order aberration, specifically coma and spherical aberration. The group with the femtosecond laser also had a better defocus curve. This shows the visual acuity is the y-axis, and then kind of the refractive error additional diopters you can see on the bottom. So you can see that the blue is the femto group, and it does show slightly higher vision at these different time points. And you can also see that cluster is more, the blue circles are right in the middle versus the red that's more scattered. Precise capsulotomy. So what's another advantage of it? So as Nick showed before, there are the femtosecond laser will break up the nucleus into small pieces. So really you just need to groove a little bit and you can go ahead and crack the nucleus. We don't have to go. So personally, for my technique, I usually groove in the center and go pretty deep and then crack the nucleus in two and then bring each one each half up. But here you really don't have to go too deep. Maybe a third, at the most a half, and you should be able to crack because there's already a plane created by the laser. So the posterior capsule rupture rate of 0 to 2% has been reported with femtosecond laser. And that's lower than the reported incidence of 0.18 to 5% with manual surgery. And so there have been surgeons that have said that it's faster because obviously you don't have to spend as much time doing the grooving and the cracking and less energy as well.